Atypical corneal ulcer refers to the certain corneal infection caused by microorganisms that are not commonly encountered in clinical practice. It is often associated with worse visual prognosis and significant ocular morbidity if not identified and treated early. If any risk factors that is pertaining to specific atypical infection, it should raise a high suspicion of the specific atypical keratitis. As atypical infections are notoriously difficult to grow on cultures, so a diagnostic strategy will be helpful in identification of the rare causes of microbial keratitis, and it is highly warranted. So most common causes of atypical microbial keratitis can be classified into bacterial, like Mycobacteria, Nocardia, Burkholderia, and Achromobacter. Parasites such as Acanthamoeba and Pythium insidosum. Fungal like Microsporidia. So coming to our case, my patient was a 65-year-old woman who was former by occupation. She came with a complaint of ocular trauma to the left eye with a tree branch while working in the field 2 weeks back. Following which she developed pain, redness and watering and associated diminution of vision, which was worsening over the days. She also gave a history of intolerance to light and associated with some discharge. Patient consulted to outside hospital immediately after the trauma. She was told that she had an eye infection for which topical medications was started. 3 days later, she underwent an eye injection and subsequently referred to our hospital. She did not have any other negative findings and no systemic comorbidities. Her general examination and gross ocular examination were within normal limits. Her vision in the right eye was 6/9, which was explained by cataract, and other anterior segment examination had no significant findings. Left eye vision was hand movements close to face and PR being accurate. Eyelashes showed matting and with the presence of lid edema, but lid closure was adequate. In this picture, we can see circumcorneal congestion, and in the cornea, there is presence of pinhead-shaped infiltrates surrounding the corneal ulcer of size 6 into 6.5 millimeter with surrounding stromal infiltrates. Also, there was endothelial plaques, and anterior to that, there was stromal infiltrates. Satellite lesions were seen adjacent to the corneal ulcer, and there was obvious AC exudates and hypopyon, which was partially mobile and was measured to be 4.2 millimeter in height. Corneal sensation could not be elicited as patient was having photophobia. Other anterior segment examination in the left eye could not be elicited as patient had corneal ulcer. IOP was digitally normal. So my clinical diagnosis would be left eye corneal ulcer. I would keep my first differential diagnosis as bacterial keratitis since it's most common, followed by fungal keratitis, and then atypical and polymicrobial keratitis. We did our first corneal scraping, and it was showing no organisms in Gramscian or KOH. We empirically started the patient on antifungals like natamycin and amphotericin B, and antibacterials such as vancomycin and tobramycin, along with cycloplegics. Since patient did not show any improvement, and ulcer was also progressive, so we took the patient for intrastromal and intracameral antifungal injection after the anterior chamber wash of exudates. Intraoperatively, after the anterior chamber wash of exudates, we could clearly see the V-shaped pattern that was emerging very much clearly. Ulcer was scraped, and the exudates and the scraping was sent for microbiology. We also gave intracameral injection of moxifloxacin. Based on this typical pattern, nocardia was suspected, and medications were modified into amikacin, linezolid, and moxifloxacin. Patient symptomatically improved, and culture also showed chalky white colonies on blood agar, which confirmed the nocardia keratitis. Ulcer size was gradually reducing, and hypopyon was disappearing. We could see that with appropriate treatment, the cornea is becoming more clearer and hypopyon is disappearing. The V-shaped pattern was clearly noted here. So antibiotics were slowly tapered to QID dosage and stopped. Nocardia is a rare and frequently misdiagnosed cause of corneal infection. Nocardia is found to be prevalent in soil of South Asia. It has associated risk factors like prior ocular trauma with soil or dirt, and prior ocular surgery such as refractive surgery, topical steroid use, and contact lens wearer. The diagnosis of nocardia keratitis is often missed or delayed due to the lack of familiarity and an unusual pattern that mimics more common causative organisms. So the management of nocardia keratitis has a variable response to most first-line medications used for bacterial keratitis. Though topical amikacin is the first-line agent, in some cases like refractive corneal ulcer, second-line treatment like topical tobramycin, imipenem, and linezolid can also be potential options. So the empiric therapy should not be delayed if there is a high suspicion of nocardiac keratitis. The topical therapy should be continued until a complete resolution of the infection. The prognosis depends on the corneal nocardiac keratitis. They heal very rapidly, resulting in scarring and vascularization. But delay in management can lead to nocardial scleritis. Rarely they can progress into complication like endophthalmitis or corneal infection, leading to permanent blindness. On follow-up, 1.5 months later, ulcer healed completely with corneal scar. So antibiotics are tapered and stopped. Now patient is registered for optical PK and she will be called for after 3 months of drug-free period. Here the learning points from our case will be that knowing the typical finding of nocardiac keratitis, so its timely detection and its management brings us a favorable clinical outcome. Thank you.
So is it a routine practice to wait 3 months after cessation of the treatment?
We should be sure that the nocardiac keratitis has resolved. So the corneal scarring might be there, but after that we should wait for at least 6 weeks to 3 months to be called for PK.
So did you do OCT to decide whether to do lamellar keratoplasty or optical keratoplasty?
She's still under the topical medication, is still not stopped fully. So after that we'll plan for corneal transplantation.
So, as residents, are you routinely doing corneal scraping? Because sometimes if you have not done it properly, then maybe you don't get in the microbiological examination. So, are you routinely doing for all cases, and what all culture plates do you plate for a case of keratitis?
The first scraping was found to be negative only. Second scraping and X-ray showed the nocardiac keratitis. It might be that the specimen was not adequate enough to show to show in the gram stain or KOH. And for this case, routinely we do blood agar and seborrheic agar. In this case, in blood agar, it shows chalky white colonies.
Okay. Thank you, Priyanka. That was a wonderful presentation, but one thing I am disappointed with you is you didn't cite my article. We have a review article on atypical keratitis. So in current eye research, it's a review article, you all can follow that. So apart from that, that was a nice presentation. Only few things. See, when would you suspect an atypical keratitis? That is important for all of us to know.
First thing, the most common will be bacterial or fungal. So if the patient is compliant enough, but still the ulcer is progressing, we could think about atypical keratitis. And second is that most of the atypical keratitis can mimic fungal also. So they will have more the signs other than symptoms. So even if the patient is compliant with the empirical antibiotics, still the ulcer is progressive, we can think about atypical keratitis.
So I won't say it's progression. Any keratitis where you are giving full treatment and the ulcer is neither progressing nor healing, and it's already 1 month or 2 months, it's saying like that only. In those cases, you should suspect atypical keratitis, because most of the atypical organism, they don't progress that rapidly, and they are sensitive to routine antibiotic, but not fully 100%. So there will be some response, but again that may flare up or it may remain static like that only. And then you should suspect atypical keratitis. And nocardia, would you give steroid in nocardia keratitis?
No, we don't give steroids. Only if it's only stromal involvement, then it will be more of an immune reaction rather than the organism actually. So actually in this case, it was ulcer more than the stromal reaction, so steroids are avoided.
And what about that amikacin? Initially you started with 2.5.
Yes, sir.
Okay, then you made it 1.25.
Yes,
Any rationale for that?
First we start with the high dose so that the ulcer progressive will be reduced. Then we can slowly taper.
So any opinion from the experts whether to reduce the dose completely, like reduce the strength, sorry, or reduce the frequency? What should be the right approach while tapering topical antibiotic, fortified antibiotics? Dr. Jaya, one of our panelists is sitting there, so I would like to ask her. So whether she will prefer just taper 2.5% gradually and stop, or reduce the strength to 1.25 and then continue for a long time. Yes, because you know, the MIC, But you are giving 2.5, right? So the moment you make it 1.25, there are some organism dormant, they may flare up. Okay, so because remember when you are giving antibiotic, your bacteria or fungus, they are also starting their protective mechanism. Okay, so now the organism also well prepared to tackle 2.5. So if you make it 1.25, then there will be problem. Okay, so don't reduce the strength to which the organism is responding. Better to taper it off gradually. Any other comment from panelists? Anything from the house? From all the PGs? This is MCQ for you all, okay, that typical appearance. Can you tell us what is the origin of this, how this term is coined? Which are the other synonyms? Chalo, this is a quiz question. We'll be doing in 16th March, Ajanta Pharma Science and Fun quiz. All of you are welcome. A question will be there on this, okay?
It mimics ring infiltrates.
No. Anyway, thank you.